Thank you for the kind introduction. Actually, I visited this state for the first time. And honestly, I wasn't know exactly the location before. Sorry about that. When you live in Texas for more than 2 decades, sometimes you forget the Northeast exists, actually. That's a joke, actually. The goal today is to really talk about best practice of inflammatory breast cancer. So 80% of my talk will focus on what will be the best care for IBC. And then toward the end, I'll talk a little bit about research and where things are heading. Okay, so there are certain facts that I need for you to understand. IBC is one of the most aggressive forms of breast cancer. It represents probably about 2 to 4% of breast cancer in the United States. Unfortunately, because of the aggressiveness, if you look from the mortality perspective, the US breast cancer mortality, it may represent close to 10%. So when you are seeing a lot of a newly diagnosed breast cancer, you may not feel like this is a really a social health issue, but when you come to clinic with a lot of advanced disease, you'll suddenly notice that there are many patients who has history of inflammatory breast cancer. When you look at the world level, if you go to like North Africa or West Africa, like Senegal, Egypt, okay, the diagnosis of inflammatory breast cancer could represent about 25 to 30%. And this number fluctuates between like 15 to 30, but clearly it is much higher than what we see in the United States. Initially, a lot of people felt that this is due to it's a developing country and it's a delayed diagnosis, and that's actually mimicking the inflammatory breast cancer. But there was a team from the United States who has, from the NCI, visited these countries and confirmed that indeed, for some unknown reason, that the incidence of inflammatory breast cancer is high in North Africa. So why is it aggressive? And there are a couple things we need to talk about. One is by the time the patient presents with inflammatory breast cancer, and I'll talk about the features of IBC later on, but like the redness of the breast or the breast engorgement, 1/3 of the patient will already have metastatic disease if you conduct like CT scan or PET-CT scan. There's tendency to not to respond to standard like chemotherapy. And even despite a good response, they have still a tendency to disease to come back or metastasize. So you can see here that these are different colors with different curves from the 70s, 80s, 90s, and 2000s. And these are survival curve. And you can see that the curve is pretty much overlapping. And this is MD Anderson data, and we have really made a lot of effort of trying to improve the treatment, but the actual survival data hasn't really improved that much. So the question is what to do about this. So we have some challenges. So the challenges is why inflammatory breast cancer is difficult. Well, it's a clinical diagnosis. Many disease actually has clinical diagnosis, but over the past 2 decades, what we call molecular diagnosis. So there's some kind of genetic testing or certain characteristic that you could actually confirm by microscope and confirm the diagnosis. But IBC is more of what you see decides what you have. And that sounds kind of okay, but when you actually do research, it makes it difficult because the definition is not very clear. And then this IBC is very heterogeneous. So even this IBC will have estrogen receptor positive IBC, you will have triple negative IBC, you'll have HER2 IBC. So that adds more complications. And what makes it more difficult is laboratory research. So in the past, we didn't have enough cell line, even animal model to conduct the research. And so if you don't have a lot of research samples or research models, it makes it difficult. So why is it difficult to get research sample? Well, the breast is engorged, but it's not a mass. So the disease is scattered over. So it's not like regular breast cancer. You stick a needle and you get a chunk of tissue. And sometimes you do, but probably there's more than 50% of the time you will not have sufficient amount of the tumors. So if you don't have a lot of research, you end up having not a lot of clinical trials. And particularly, maybe like 10 years ago, there was really not a lot of trials. Currently, like Duke, Dana-Farber, or MD Anderson, or Northwestern, there are some university that's very focused on inflammatory breast cancer, so there are more clinical trials, but still it's very limited. I mean, if you think like West Coast, I don't even know who I should really refer you for the IBC specialist. So let's talk about standard care of IBC and what we need to do. And I'm going to go in more details, but I want to like for you to understand the flow of the care. So one thing is that the moment the patient comes, we would like to get mammogram, ultrasound, MRI mammography. We would like to get consult with surgery, radiation, medical oncology, EKG, echo, PET-CT or CT scan, bone scan. So pretty much we will schedule all above testing and consult probably within the first 1 week. We will make that effort. And particularly the key is to make sure the surgeon, the radiation oncologist will see the patient before the medical oncologist start some kind of chemotherapy. It is not a good practice, just blast with chemo and towards the end you will have a surgery like what we call modified radical mastectomy and have the surgeon come by and, hey, let's take it out. Well, yeah, well, it's the same surgery. No, it is not the same surgery because the surgeon and the rad-onc have to really see the original extent of the disease where the skin was red. And these are very important. And that's one of the key things that sometimes in community practice, it does not happen. And what happened is that because it's not confirmed up front, the extent of disease is not confirmed, so there is always a chance that you may not take the tumor out completely. So the key is that it is important to give chemotherapy before surgery, okay? And as you know that there are two ways of treating breast cancer. You could do surgery and chemotherapy, but the bottom line of the current standard care for locally advanced breast cancer, including inflammatory breast cancer, is to provide what we call neoadjuvant chemotherapy or preoperative chemotherapy. And why is it important? Because when you go for surgery and you look under the microscope, and if you could confirm there is no disease, what we call pathological complete response, PCR, the outcome is better. And you could see that this is a disease-free survival and probability of DFS over like 1 decade. So if you achieve pathological complete response in IBC, which is the blue line, and the red line, which is non-pathological complete response, you could see the chance of disease coming back is very different. But there's something that I need everybody to notice, which is very different from the regular breast cancer. So could anybody say what's different? Okay, so the difference is, yeah, what?
Plateau, the steep decline in plateau.
Yes. One is, yes, steep plateau for the PCR, and one is a real rapid, decrease. That's one thing for sure. But what I'd like for you to, like you just mentioned, the plateau, despite the PCR, meaning that the tumors melted away from chemotherapy, there's still about 30 to 40% chance disease may come back. Now, this is a little bit old data, So I know some of you are patients, and then I'm not trying to scare you. This is 5 to 10 years old. So currently probably the curve is a little bit more upswing with the current conventional chemo, but still comparing to non-inflammatory breast cancer, even with a great response, that disease could still come back. That means that there's a different mechanism that drives the cancer to become aggressive. All right, so then the next characteristic is that this is a little bit busy slide, but it has black as a triple negative, which is a ER negative and PR negative, HER2 negative. And then the blue is hormone receptor negative, HER2 positive. The red is hormone receptor positive, HER2 negative. And the green is hormone receptor positive and HER2 positive. So different molecular subtype, typical thing you see in breast cancer. So the left is what we call the disease-free survival, and the other one is overall survival. So this is what we see with inflammatory breast cancer. Okay, so this is also as a data, okay, very different from what you know from the regular breast cancer. So what's different? This curve is something not right if compared to if you're just treating regular breast cancer. What's not right? Okay, so what's not right is estrogen receptor positive patient don't do well. So usually, if it's a non-inflammatory breast cancer, the curve will start separating. So everybody talks about hormone receptor positive breast cancers. They're going to do well. You get hormone therapy and life is beautiful. Well, here you could see that, of course, the triple negative is probably have poor prognosis compared to the other subtype, but all the line is pretty much kind of all together, right? So one thing I need for you to understand is that this disease is intrinsically derived from the original characteristic, and it's not simply derived by like estrogen receptor positive. So if a medical oncologist says, oh, you're ER positive, you're very lucky. Well, you're lucky from sense of providing some kind of treatment, but it's hard for me to say that you're completely out of the wood. And these are information that sometimes many of our breast physician, even with an academic breast physician, may not recognize. So let's talk about how they present, okay? And I pulled this from Dr. Beth Overmeyer's Dana-Farber site, which was very nice to really provide like redness of the breast swelling, pain, thickening of the skin, and lymph node positivity. Yeah, so these are the typical findings that we like to see, okay? And in the success of the advocates like Terry Arnold, trying to tell what is important to recognize for the IBC, which is nice, but there are some issues that you need to understand because some patient will present with like a very small amount of redness. Okay, so they come early actually. So now we're detecting these patients doesn't have the entire breast swollen, but locally just kind of swollen and it's red. And then we don't call them IBC and they are going to mastectomy. And after the mastectomy, they go into this rapid progression. So in the past, good or bad, you give antibiotics, right? And you give a second round of antibiotic because you believe that it's more like mastitis or infection, and there was a delay, and the redness continues to spread. So therefore, by that time, you meet the standard criteria of like, oh, this looks like inflammatory breast cancer. And those are definitely an issue for us, but the question that we're facing now is what is appropriate way to make a diagnosis of IBC, because we may capture this disease early and then you feel like, oh, we need to take them to surgery because it's small. And then and if sometimes, fortunately or unfortunately, while we're working up the patient with all kind of testing, within a week it spreads and it's suddenly says, oh, it's IBC. But sometimes that opportunity may not exist. And those are the dilemma that we're facing. So I'm showing you a very, I'm sorry people if you get nauseated, but this is a very extreme presentation. So this is really, swollen, the color is changed. Yes, I mean, we don't see this type of IBC very recently because of the awareness, okay? Rather, it's going to be more toward like swollen, and you could see that there's a skin edema. You could see these follicles, and then that you could see, and there's a color change between the area. So those are probably still the second common one. So this is more common that we see these days. It's hard to say, but you see the left, okay, comparing to the right, it's swollen, right? I know it's a little bit light, too bright to see, but you could see the color changes. It's actually just some redness here. And these are the things that we will call IBC. And then if you do like PET-CT scan, you could see that there's skin thickening comparing to the before, and you could see that the FDG uptake is all over the places, so it's very active disease in the entire breast. And more difficult one that we are currently seeing is like this one. See, it's really slight redness. And then this breast actually, 2 weeks later, it really went to like full-blown IBC. So we have to suspect, and we have to really pay attention. I mean, I'm not trying to suggest to you that you should wait and see what happens, but I want you to understand that there's a kinetic. Woman and, male breast cancer is only about 1%, but woman does have more awareness about breast cancer, but the awareness is generally focused on a mass, not focused on skin changes. Further, there's not too much of focus on the kinetic of the redness. And it's not just about for the patient, but even at the physician level, this awareness is completely missed. So you start to wonder that whether we're missing the diagnosis of IBC. And you have to remember that MD Anderson is a tertiary cancer center, and some patients, the disease progression is so fast, so if you were able to come to our hospital, already we have a bias, right? Because some people become ill so fast that they can't come to like a large cancer center. So there are probably that we're estimating that there are a lot more patients out there that who is not potentially receiving appropriate care. Okay, so let's talk about diagnostic imaging. So at our centers, we do look into 3 imaging modalities: mammogram, breast ultrasound, and MRI mammography. So the mammogram is an important tool for screening, and I think the first thing to consider is mammogram. But and what could you see? Well, skin thickening, trabecular thickening, trabecular distortion, increased breast density, calcification, axial adenopathy. Well, we see this, but you have to remember that we also see patients who has nothing actually. So they have the typical clinical features that I just showed you by the picture, but the mammogram is completely negative. That doesn't mean that you don't have IBC. You still could have it. The other issue you face is mammogram is so painful, so adequate, particularly for IBC patient, to go for mammogram is very difficult. So adequate mammogram is not conducted, and so therefore there could be a delayed diagnosis, or the imaging is not adequate, so you may not find the abnormalities. So the issue of mammogram is it's the least sensitive modality, and it may not be the most helpful diagnostic tool. And once again, I'm not telling you not to do it, but whether that's going to be helpful once you make that toward the diagnosis of IBC. Is mammogram helpful? We always we still do it, but it becomes a little bit question mark. So what's helpful is ultrasound and actually the MRI mammography. And there are certain characteristics like delayed washout with a plateau curve, which is very common in IBC, which will help to make the diagnosis of the IBC. And then you could see a lot more disease in the MRI and but followed by ultrasound comparing to the mammogram. And this is very important because for the surgeon, well, for the medical oncologist, we're the drug dealer, so therefore, the imaging doesn't really have a significant impact. Rather, the impact comes from the surgery that we were just talking about. So having a real good baseline imaging like ultrasound or MRI mammography for the radiation oncologist and surgeon, it will have an impact. So if you don't have an imaging, you will go by what's written in the chart. And further, if you don't have any picture, so if you don't even take a photography, you don't know what it looks like. And this is another issue that I commonly get. You get a referral from outside, there's not a single picture, and I can't tell what it looked like. The patient is actually doing a selfie with their breast in iPhone, and I'm actually pulling out the selfie picture and putting into our medical record. And the patient is doing the right thing, but the physician don't document. And it's important because that tells you the kinetic of the symptoms that you see. All right, so now once you know there's a clinical future imaging, now you need to do the biopsy. So the main biopsy obviously is a core biopsy, and then if you have a lesion, if you have a mass, of course you should put into the mass, right? I mean, of course. The problem is when you don't have a mass, you don't see anything, where do you go? Okay, so you go to the most suspicious area based on MRI or ultrasound. Now, if you don't see anything at all, where do you go? Well, you do a blind biopsy. And in addition, it's very important to map all the nodes, the extent of the lymph node, not just by imaging, but confirm where is your lymph node positive or negative. And that's going to be very, very helpful for the surgeon and the rad-onc. And then you should consider skin punch biopsy. Now, the tricky part is I show you the breast is red. The red area doesn't mean there is breast cancer. We do suspect there's a breast cancer, but surprisingly, the red area does not mean that they always have the disease. Actually, the normal area, the normal looking area may have a biopsy. So sometimes we have women who has these typical symptoms, and then we done all the imaging, but the biopsy first time is negative. So what do? You bring the patient back 2-3 weeks later, and you do the biopsy again. And if you don't make a diagnosis, you may have to do a biopsy again. You don't say bye-bye, and then let's see you in 6 months. That's actually really not a good practice. Now, of course, I do have like 2 patients that even with every effort, we couldn't make a diagnosis, and we still don't know. The breast remains to be swollen after even 6 months, 1 year, and there's no breast cancer. I mean, could that happen? Yes. I mean, I actually have those kind of patients. But it's a scary feeling I have. But many of the patients, by doing a multiple biopsy, you could make that diagnosis. Now, what we need to remember is that the biopsy under the imaging is very painful, more painful than non-IBC patient. So in our clinic, we highly recommend to provide some form of pain medication in their hand. Now, you don't want them to take the pain medication without consulting with the people who biopsy. So in our case, we try to write the prescription. They go to the clinic, to the biopsy clinic, and then depending on the location, how painful it may become or it may not become, our radiology will say that please take the pain medication or don't take pain medications. So comfort is very important. So then when we do the pathology, we commonly see a very poorly differentiated nuclear grade 3, Ki-67 is very high. It's usually invasive ductal carcinoma. Can you have an invasive lobular carcinoma? Yes, not common, but you could see it. And you could see tumor emboli or dermal lymphatic invasion. Okay, so the typical pathology that sometimes we get. Diagnosis of inflammatory breast cancer written on pathology report. Okay, they do not exist. Okay, you cannot make a diagnosis of inflammatory breast cancer on pathology. They had these features, so you could suspect it, but you can't make a diagnosis because nobody, just expert, has said that because you have tumor emboli, you have IBC. So the moment you see that kind of a pathology, to us, it's a concerning. I mean, it may be true that it's a patient has IBC, but is the pathological review done correctly is something we start to think. So it is not it's not based on pathology. You do have to have a breast cancer. Okay, you don't have to have a tumor emboli, you don't have to have a lymphatic invasion, but as long as the breast is red, you can make a diagnosis of inflammatory breast cancer. So let's look at the molecular subtypes, and then the molecular subtype for IBC and non-inflammatory breast cancer. So the non-inflammatory breast cancer that we all know, roughly about 65 to 70% of the patient will have what we call estrogen receptor positive disease, and triple negative is 15%, and there's what we call HER2 positive disease in this area. But you could see in this pie chart on the IBC on the left side, 36% of the patient will have estrogen receptors. So it means that, one, the prognosis is not no difference among these molecular subtypes, but the chance of having ER positivity is less. There is more triple negative inflammatory breast cancer, and there may be a little bit more HER2 positive disease. Okay, so where could the disease spread? I told you that when the patient comes to the clinic and they may say, well, my breast got red about 3 weeks ago. I tried 1 week of antibiotic, and now we do biopsy, it's a positive disease. Then we do CT scan or PET-CT scan, working to find the disease. Well, it could be in chest wall, contralateral breast, adenopathy, lungs, perfusion, bone, liver, and brain. And one thing that's really important is the contralateral breast. So there's a tendency that we focus on the one breast, and then you don't look at the other breast very carefully because you see all disease in this area. But we find quite a lot of contralateral axial lymph node involvement. And you'll be surprised that sometimes they even have different type of breast cancer on the right side. So paying attention into the contralateral breast is very important. And clearly, because of the high rate of metastatic disease, it is important to stage the patient appropriately. So the question is, what should we order? Well, with the era of this insurance company, getting a PET-CT scan is very difficult, but as written in the NCCN guideline, or even in our guideline, we highly recommend to get PET-CT if you can. I mean, it's not that PET-CT is superior to CT scan with contrast and bone scan, but there are certain things that actually is very helpful in PET-CT. So one is, once again, everything that we talk about is helpful for the surgeon and the radiation oncologist. Not for me, but it's helpful for them because one is this precision of radiotherapy relies on the extent of lymph node. So you do all these ultrasound and you identify abnormal lymph node, but the PET actually lights up with a normal node, surprisingly sometimes. And then you have to start looking carefully and biopsy this area because surprisingly, the lymph node extension is more than you think. So the regular CT or the ultrasound I just talked about may not capture it. So you have a chance that you could be missing locally because you didn't do the right testing. Now, we don't have a prospective data to prove that this is better. So I can't claim that PET-CT have to be absolute standard, but what we did among us in our group is that we agreed that we would try to get PET-CT scan as much as possible. Okay, so this is a newly diagnosed IBC. It's a PET-CT scan. PET scan and PET-CT, and you could see that the breast is like, there's a black ball. I did not put a ball there, just there. It's the breast cancer sitting there, and it's really hyper, right? So it's a very active disease. Sugar uptake is high. You don't see this kind of high activity with a non-IBC. These are the lymph node involvement. In this case, these lymph node involvement that you see is not always clearly seen with a CT scan or ultrasound. And this imaging is very helpful to be completed before your systemic chemotherapy because the radiation oncologists have to decide what kind of boost they give, what is the extent of the field they should be radiating. Okay. So what do we do with a brain? Okay, so when you actually look into IBC, comparing to non-IBC, clearly there is a higher rate of brain metastasis. That's documented. However, currently we do not have a data to suggest that we should be screening these patients with an MRI of the brain. But if they have headache or any kind of neurological symptoms, even if it's mild, we highly recommend to obtaining an MRI of the brain so that we do not miss any brain metastasis. Okay, so let's talk about chemotherapy. And then I am not here to sell MD Anderson, okay? So from all the fairness, I will talk about the other institution. We have actually had a discussion with Dana-Farber, Duke, and trying to make sure that we have a consistent practice in the United States, but still there may be slight difference. And I'll first talk about MD Anderson approach, and then I'll kind of I'll compare with other institutions where the difference is. So the first thing is that we should give chemotherapy, but one of the things that's most important, like in triple-negative breast cancer, is to provide Taxol or AC. You could give dose dense or you could give weekly. We don't really care. We don't care which sequence you start, but it is important that both taxane and anthracycline is provided before surgery. And I'm going to emphasize this very much. You do not give TC chemotherapy, okay? Not Taxotere and cyclophosphamide. You don't give Taxol and you don't stop, okay? You have to give Taxol and AC. We're talking about 4.5 and 6 months, okay? Whatever it takes, you give chemotherapy. I know it's terrible. I know we're talking about the de-escalation of treatment, but in this case, you have to shrink it, okay? You have to give it, okay? And particularly in triple negative, you may want to consider adding carboplatin, particularly with like weekly paclitaxel, to further enhance the response rate, because achieving pathological complete response is the only data we have that would show that it would improve the outcome. And I'm going to emphasize this like crazy. You have to give chemo and you have to give it on a timely manner, because I'm going to tell you that 1/3 of patients that I end up seeing consult is that the treatment got stopped or they can't deliver the chemo in a timely manner. And the patient said, well, doc, I don't want to torture the patient, but you have to understand the outcome is highly dependent on the response. Estrogen receptor positive IBC, same thing. Why? ER positive, you give chemo aggressively? Yes, even the same thing. You have to try to shrink the tumor as much as possible. HER2 positive, our first choice is to give THP, Herceptin, and pertuzumab 4 cycle, followed by AC. Okay? We have not yet decided that we could go with TCHP times 6. And this is actually that it's not that we have evidence, but our backbone of our treatment has based on taxane and anthracycline, and dropping anthracycline has been very difficult to practice. So if you say, well, do we have sufficient of no anthracycline regimen, the answer is we don't. Okay, so this is Anderson and Dana-Farber and Northwestern, okay? Pretty much we're exactly the same, okay? I'm not gonna go through this, but it's exactly the same. Dana-Farber is making an effort to drop the AC in HER2 positive disease. They're trying to give only HER2 targeting drug and taxane. If they get a fantastic response, okay, they should probably go without AC, and that's a great idea. So, but that is done under clinical trial. That's because I told you that we don't have evidence. MD Anderson is actually going on the other way around. So now we're giving 3 anti-HER2 therapy for the HER2 positive disease. I'm not saying that we're right or they're right. We just don't know. One is more intensification, one is more de-escalation. But the middle ground is what I just talked about, okay? So the question is that what do we do for adjuvant therapy, okay? So for triple negative, the CREATE-X data has clearly shown that if you have any residual disease, that it will benefit from gemcitabine. Now that data was not based on inflammatory breast cancer, but taking additional gemcitabine with any residual disease may have a benefit. So we do talk about this. The other is estrogen receptor positive disease. We highly recommend to suppress the ovary and consider aromatase inhibitor with a soft text regimen, and that's our first choice. And for HER2 positive, all patients, regardless of the response, we recommend pertuzumab and trastuzumab because they are considered as a high-risk treatment. So I know some of you are not in this field, but what I'd like for you to understand is that our stance of our group is that we provide the treatment based on certain evidence, but not definitive evidence, but because of the relapse rate is so high, we try to provide the entire treatment, and we try not to de-intensify the treatment unless we have a clear evidence. Okay, and then pretty much that when we talk with MD Anderson, Dana-Farber, Northwestern, Duke, we're all the same. So your choice of looking for expertise, yes, if all of you could come to MD Anderson, I'm very happy. I know we're taking video. That's not the reason. But I think it's really good to go to like Dana-Farber or Duke or Northwestern or us, any places. Probably they have same principle. We may say slightly different thing, but the principle is very similar, okay? So let's talk about surgery, okay? So the bottom line is modified radical mastectomy with axillary lymph node dissection, okay? Currently, there are no other choice outside of standard care. So here's a couple things I would like to talk about. No skin sparing. No breast conservative surgery. Currently, in the United States, there are no data that this is a good practice. Is it possible? Maybe. The UK has suggested it, but we are not practicing it. Okay. We do not recommend immediate reconstruction because a high rate of relapse in the first 1 to 2 years, maybe 1 year. So at least we recommend waiting 1 year. Okay. Get the surgery done, move on to radiation, and wait. Now, the other thing that's important is no immediate prophylactic contralateral mastectomy. Many women will come to us and say, please remove the both breast. Okay, not to me, but the surgeon. Okay, and so why? Okay, well, it's because if you remove both breasts, the complication rate comparing to unilateral mastectomy is much high. If you have a complication, you will delay the radiation and you will delay other form of necessary adjuvant therapy. And that is detrimental to the outcome. So we highly recommend two-step mastectomy unless there's an immediate need for some kind of medical justification that both breasts needs to come off. And this is something hard to swallow for the patient because even if you're not BRCA positive, still there fear that it will come back on the other side, and I totally understand that. But the key is to really calm down or face the IBC on the ipsilateral breast first, and then worry about the contralateral breast later on. So we're pretty much agreeing, except for the UK. UK always have a different opinion for different reasons. That's a joke, actually, but we all agree that it's important to do modified radical mastectomy, axial lymph node dissection. Sentinel, identifying sentinel is very difficult. We have already done clinical trial, and of course, women who have IBC, the breast is big, there's a tendency for the weight BMI to be on the higher side. So they are very high risk for lymphedema, okay? But unfortunately, that when we do sentinel mapping, the dye will actually permeate all over the place to the point that you can't really reliably identify the sentinel lymph node. So we do not recommend doing sentinel lymph node. Rather, what's more important for lymphedema is that if the woman, really if you have a lymphedema clinic or physical therapy, it is important to really referring the patient early, and then these days they may do what we call lymphatic channel reconnection type of thing. I'm not saying that should be a standard care up front, but every player that's related to lymphedema should try to be involved in the care as early as possible for the patient who has IBC. So the radiation therapy, all women should receive, or men should receive radiation therapy. By the way, men do get IBC, but the chance is probably about 0.2 or 0.11%. So it's usually in a non-IBC, it's about 1%, so it's very uncommon. So what kind of radiation do you give? Well, there actually, if you received the chemotherapy and surgery, and if you have a lot of residual disease, Dr. Woodward will recommend doing twice a daily radiation for I think like 4.5 or 5 weeks. And if you have a real good response, she'll recommend once a daily over like 5 half and 6 weeks. But I'm not a radiation oncologist, but my understanding is that I keep reminding everybody about like PET-CT and ultrasound, and then seeing the patient up front, she will remember the whole area and she will customize so that she really will boost the area that's concerned for recurrence. Okay, so this is a controversial topic. People who have de novo stage 4 inflammatory breast cancer. So currently, using our standard standard staging, inflammatory breast cancer does not exist in stage 4. Okay, It's like, what? It's like, it's true. AJCC only defined inflammatory breast cancer existing in stage 3. But we all know that patient will present with IBC and they could have metastatic disease. And once you have metastatic disease, they will bundle all together and call it stage 4. And so the word stage 4 inflammatory breast cancer is something that our group and many of the IBC specialists recognize, but there are some breast physicians that who will not recognize the existence. So why is this important? How do you treat women who have metastatic disease and they have IBC in the breast? Well, some people say, well, you should, because this is not a curable disease, so let's just give you some kind of systemic treatment and see how you do, okay? Well, that's not a good approach. We highly recommend that first thing is whether you could apply like a stage 3 inflammatory breast cancer approach, meaning that you give systemic chemotherapy, try to shrink the tumor as much as possible, and then to consider potentially surgery. Okay, so that's really like why is he talking like this? Because in non-inflammatory breast cancer, there has been already randomized clinical trial to show that surgery does not improve survival. Well, there's a reason behind this. This is not simply about improving the outcome and how long you live. If the breast does not get control in IBC, it becomes a major quality of life issue and wound care issue, smell and suffering of the patient. If you ever taken care of patients who have extensive entire chest wall involvement, it is a total disaster and really bad situation for the patient. So to prevent this, okay, it is important to think about doing a palliative surgery. It may not be curative intent, but doing surgery in this condition to do a good local control is important. You don't want to take women who's not responding to go for surgery, but if they're responding well, it's important to do the surgery. But if you're going to do the surgery, you need to make sure that you have mapped the lymph node and extent of the disease very carefully, because with one mistake, okay, the surgeon may miss the area. And this is where the surgeon, rad-onc, and med-onc have to work very carefully. So if the team does not exist to really work together closely, it is really not just, it is not a good idea just let's just do the surgery, because a mistake will, there's a high chance the mistake will happen. It is important to go to a clinic that's really has 3 disciplines that could see the patient almost same time and make that decision together. Okay, so MD Anderson has been dedicated, and we call ourselves as Morgan Welch IBC program, because Ms. Welch, who was diagnosed soon after the wedding, and she passed away at the age of 24. So about 11 years ago, we dedicated, the advocates and the state has advocated for that we need to create a clinic, and that's really the start of our clinic. And then, so there is a lot of international consortium, and then a fantastic investigator from this area, and then we have currently a registry that we try to collect samples, and we try to come up with a consensus of how we treat our patients. So public education is a key, and I think this has been somewhat getting this opportunity to talk is really fantastic, and so increasing the awareness has really helped to improve how we treat the IBC. We also have a website that provides video. This video is slightly old, and we're trying to update this, but we have a professional education site. If you're interested, please email me, and I'm happy to send you the link. And it talks about much more details than what I'm talking about, but we're trying to really increase awareness for better treatment for the IBC. We also have social media activity from Facebook to Twitters, and we're doing like a Facebook Live on a monthly basis. So it's a small dent in this community, but one of the things is that this IBC is rare, and the rare disease still matters, and what we can make a difference by working together and trying to increase the awareness. Okay, so now the last part, okay, and before you go to bed, and this will be a nice way to go to sleep, I'll talk a little bit about research. Okay, so we constantly talked about different research ongoing. And one of the challenges that we face, and I'm going to oversimplify some of the effort that's been going on, and one is looking for unique gene signature. Okay, everybody wants to know why is inflammatory breast cancer aggressive. So people compare to IBC versus non-IBC, and the funny part is that everybody come up with their own unique idea, including myself. Okay, I'm as guilty as anybody else, and claim that this is the reason that IBC is potentially it's derived from these genes. But for example, when you take like 3 paper and then look the comparison of this unique gene, the overlap was like 0 actually. So you could see that it's how difficult it is. So why does this happen? Okay. So why? So it happens because part of the issue is that we don't even know how the sample was collected. Remember I told you that the needle may go into the mass, it may not go into the mass, and anything that in the past the sample was very much unclear where the sample is. The diagnosis is not molecular diagnosis. So it's possible that from the beginning the diagnosis was not IBC. So these are all confounding factors that makes it difficult to come up with something unique. And then if IBC is not driven by breast cancer itself, then we have to think about what's happening surrounding of the breast cancer, and that's called cancer microenvironment. So one of the examples is like measuring these cytokines in the blood and then comparing to a patient who has IBC and non-IBC. And what we see is that certain unique cytokine is more elevated. So you start to wonder, is the reason for inflammatory breast cancer being aggressive is not just simply because what's going on inside of the cancer, but surrounding cancer, surrounding condition, cancer microenvironment is driving the aggressiveness of the disease. So yes, there are unique gene pathway that determines the prognosis. We can redefine the gene mutation driver. Few targets has been clinically proven. The reality is that despite I talked so much difference about how they present, but if you ask me what is a molecular gene signature comparing to non-IBC, the difference is not very clear. Only thing that's clear is that achieving pathological complete response is from the preoperative chemotherapy is very important. So this is your homework today to memorize all the targets that exist, and then so you could see that there are what we call stem nest, cancer stem cell invasion, and EMT-like. There's from PDGF, from EGF, CD44, and then, from a JAK-STAT pathway. So there are many targets that's currently ongoing with the study. But one thing I could tell you that 2 drugs has not been proven to be effective. One is that because the breast is red and it has a lot of blood vessel, so they tried to use bevacizumab, and it has not proven that bevacizumab is particularly effective in IBC. So that's one thing. 10 years ago, people felt that lapatinib was a unique drug, and this may be unique to IBC, but that also didn't work out. So currently, the 2 major efforts is one from Dana-Farber, ruxolitinib, which targets the STAT pathway, and MD Anderson is targeting the EGFR. and with a panitumumab, which is a humanized anti-EGFR antibody. And this is all clinical trials. This is nothing standard care, but we think that these are the potential two promising targets that we need to prove that this could become a standard care over this another 5 to 10 years. So my interest is in this EGFR, which is really like a brother and sister of the HER2. And EGFR as a therapeutic target, EGFR is associated as a poor prognosis. So indeed, when you have EGFR overexpressing, there is the prognosis is worse than people who are negative. So the model is that EGFR, okay, so I'm not going to show any basic science data, but when you treat with EGFR, you could regulate the inflammation. Inflammation regulates what we call TGF-beta pathway, and it regulates the stem cells. I know people are falling asleep now, actually. I could see it. So please do not worry. I will not ask questions. But we do think that EGFR has a role in inflammatory breast cancer. So we actually did conduct a clinical trial in inflammatory breast cancer. This is we published in Lancet Oncology. I'm sorry, it's in press, but it's actually, we did publish in Lancet Oncology this year that this is a neoadjuvant panitumumab plus low HER2 IBC, meaning that it could be triple negative or estrogen receptor positive. After their diagnosis, they will receive panitumumab, then they will receive nab-paclitaxel carboplatin, and they receive FEC every 3 weeks times 4, and they went for surgery, and we measure what we call the pathological complete response. So what we found in this population, so this is basically investigational treatment with inflammatory breast cancer, and what we found is that the PCR rate on the triple negative breast cancer was 47%. So, and then if you add what we call RCB1s, like tiny bit of disease left, then the 65% of the patient had what we call close to pathological complete response. And if it's estrogen receptor positive, it was 15 and 15%. So why is this very important? Okay, it's like, okay, well, it sounds like reasonable number for non-IBC. Well, so our historical data, okay, so non-IBC, you know, I talked about chemotherapy multiple times. In the historical data in TNBC with non-IBC, the PCR is about 30 to 40%. Our historical data achieving that PCR is only 12%. See this, it's only 12%, I want you to understand, okay? I told you PCR is very important, but it's only 1 out of 10 or 2 out of 10 of my patients achieve PCR. So when we see, this is a single arm study, but when we see like 44%, it's like, wow, it's like, what happened to our regimen? You know, something, you know, this could be a fluke, or this could be, you know, something that EGFR, targeting EGFR may have activity. And then we looked into these, like, the target like EGFR and inflammation, and indeed the activity correlates with suppressing these pathway. And I'm not going to go in detail, but we look for molecular markers. So currently what we're doing, because we haven't proven that this is really EGFR related, we are doing a randomized clinical trial, and we're actually randomizing between people who have anti-EGFR antibody with panitumumab versus no panitumumab. And then what we want to show is that between the two arms, this arm will have a higher PCR comparing to this one. So this is an ongoing study to prove that panitumumab has some role in inflammatory breast cancer. So we think that Anderson Group, Morgan Welch think that EGFR is an important target, and this is one of our major efforts to understand how is it related to inflammation on cancer stem cell, how does it affect the tumor microenvironment, and so we're making a lot of effort in preclinical study to understand the triple negative IBC. So there are many other things that we could target based on what we call cancer microenvironment. So this is a review that we published in Nature Review Nature Cancer Review. And what we're trying to show here is that this is all immune system, okay? And one is that targeting like immune checkpoint, targeting like macrophage, and there are many different targets and drugs that's coming up at this moment. So we're kind of excited about it because, you know, in the past, we've been focusing on giving chemotherapy and then trying to expand targeted therapy, but we really never have really chance to go into these what we call immunotherapy, because IBC has a unique immunological changes that we could potentially target. So the first thing that we've been looking into is use of what we call statin, cholesterol drug. So why is it important? Because one of the reasons that cholesterol drug is effective in non-cancer setting is because it reduces inflammation. So when you have high cholesterol, it forms a plaque in your endothelial cells, and it causes inflammation. So people measure C-reactive protein, and they try to figure out how effective these statin could be. And indeed, when you do retrospective chart review and look into whether statin is effective or not, we notice that people who take anti-cholesterol drug does better than people who don't take it. So that's an interesting data. And so therefore, we're currently trying to strategize what we could do for our IBC patients. So, and I'll just finish very quickly after just talking about strategy. One is in triple negative, we will give panitumumab. For HER2, we will try to provide 3 anti-HER2 therapy in neoadjuvant setting. Dana-Farber is going towards the other direction. We are also giving pan-HER kinase inhibitor with paclitaxel. This is before. And if you have any residual disease, for triple negative, we're trying to see if we should be considering statin. For estrogen receptor positive disease, we try to give immune checkpoint inhibitor and endocrine therapy. So this is a metastatic inflammatory breast cancer. So metastatic inflammatory breast cancer is dominantly clinical trial is driven by immune pembrolizumab, atezolizumab, pembrolizumab. So these are all immunotherapy-based therapy. One is to give standard chemotherapy, shrink it, and use immunotherapy as a maintenance, or you do like a triple combination to see if we could actually shrink the tumor much better by targeting with immunotherapy and MEK inhibitor and chemotherapy. So these are the things that we're trying to come up with a better treatment. We are also trying to do what we call TVEC. TVEC is, as you know, is used for melanoma. You inject the virus into the tumor and lyse the tumor and try to make it immunogenic. So I'm not saying that this is going to be effective or not, but standard chemotherapy effectiveness is so much limited, we need to do multiple clinical trials. And Dana-Farber has its own unique trial, Duke has its unique trials, and what's really important is to have access to these trials. So one thing, I'm going to end here, but one that's important in IBC research is that it's a very patient-centered driven research. So why is it? Because many of our, we are very fortunate to able to do clinical trial research, not because we got grants very easily. The reality was really advocate really helped us to really reach out to the politicians and community and raise money. And that money allowed to create infrastructure. And that infrastructure resulted into getting grants and conducting clinical trials. So it's one of these, Kaizen model that it goes back and forth, and that allowed us for our 10-year history to make it better. And I think it's very similar with Dana-Farber in every places. And most time it's really driven by NIH or NCI, but this is a very different disease, how it developed over the past 10 years. So the conclusion is, it's a tough disease. It's a heterogeneous disease. We do need to understand. I mean, the standard care, there's many things that we still have to address, but we do think that our future is immune system and understanding inflammation. And we believe that both targeting cancer as well as cancer microenvironment is going to make a difference. And we believe strongly that in 10 years later that we will come up with a better treatment. So these are all my fundings and our fundings and multiple patients who has been really helping us to take us to the next levels. And these are my acknowledgement. So please feel free to email me, and I'm on Twitter called Team Oncology. If you want to become friend with me in Facebook, please friend me. But please say that you send me a message that you did attend, because I cannot tell who's friending me, and I just don't like casually accept everybody as a friend actually. So, but I am willing to become a friend if you send me a message that you said I did attend that, and if you tell me that this was a good talk, then I'll further, press the button. Thank you very much.